the University of East Anglia in Norwich in the UK. And I've been working with the Institute of Nursing Sciences here at the KLE University for the last 2 or 3 years. Which button do I press? In 2013, myself and the nursing, the head of the Nursing Institute here in KLE, we applied for a grant with the United Kingdom and India Education Research Initiative, and we were awarded £50,000 to do some work with enhancing the curriculum here in India. We also wanted to collaborate with my students in the UK and give them an increased global view of maternity care so that they were able to see more about what was going on with the Millennium Development Goals, not just in the UK but globally. We've been developing research potential in both the institutions in the arena of women and child health and hope to collaborate with PhD studentships. Lots of this, my slides, the things have been said already. So optimum midwifery care is among the most effective ways in to provide high quality maternal and newborn care and thus reduce mortality. And many of the speakers this morning have already said about how important it is that skilled birth attendants are available for every delivery, and this will in turn decrease maternal mortality. The key causes for maternal deaths, and then not much different in the UK as they are in India: hemorrhage, sepsis, eclampsia, and the World Health Organization suggests that these deaths may be reduced with competent midwifery care. So we were just trying to enhance the curriculum to try to provide this competent midwifery care. And the research also suggests that traditional birth attendants do not reduce the maternal mortality rate, and it's the skilled birth attendants that do this. A couple of studies from different other countries. Malaysia dramatically reduced its maternal mortality rate back in the 1960s and 70s when midwives became the backbone of the healthcare system. And more recently, in Bangladesh, they've reduced their maternal mortality rate by enhancing the curriculum on skilled midwifery for nurses. So while India hasn't quite reached the target of 109 deaths per 100,000 live births, but they're very close indeed, from my reading, of 167 per 100,000. And many of us have already said that skilled birth attendance is crucial to saving lives. The midwifery workforce across India is not, across the world, but particularly across India, isn't uniform. And the International Confederation of Midwives have a core set of competencies that are required by those that are attending women in childbirth. As Dr. Kudkanil already said, these skilled birth attendants must be able to deliver evidence-based interventions, particularly with regard to emergency maternity care, recognising the emergency and referring appropriately. So much of the work that I did with the School of Nursing was around emergency care and for the nurses and midwives to refer appropriately. First of all, we looked at the International Confederation of Midwives' competencies. They give a very comprehensive list on the basic competencies expected from pre-service midwifery education across the world. And the ICM recommends that there is, if you're already a nurse, that you have an 18-month education in midwifery, post-nurse training, or a 3 years direct entry training. And both of those are operational in the United Kingdom at the moment. In India, though, the midwifery training is embedded still within the nurse training, so it's within the nursing curriculum. As you all know, it's a 4-year bachelor's degree with only about 20% of that 4 years allotted time to midwifery-specific curricula. Many authors have looked at the difference between confidence and competence, and although they are interlinked, I don't believe they're synonymous. So if confidence is a feeling of self-assurance in your own abilities, competence is the ability to do something efficiently and successfully. And Sharma and colleagues in 2015 concluded from work that they'd done in Gujarat that the students from the diploma and the degree programs didn't feel confident in core midwifery skills, and those were the skills listed by the ICM, the core skills. This is myself and Dr. Sudha Reddy from the Institute of Nursing Sciences and a colleague from the UK, and we were looking at, this is when we were doing the gap analysis of the competences. So it's well recognised in India that although the Indian Nursing Council would like all nursing students to attend 25 to 30 births, personally managed births, this is not always possible, and quite often the students will graduate only having 5 births possibly, but still able to call themselves midwives. And of course the male nurses would not have any births because of the cultural issues of going into the birthing room. So although they are considered to be nurse midwives, they haven't actually attended any personally managed births. So it's not surprising then that these students feel low in confidence in independently managing intrapartum complications. Okay, so the questions really that we're asking ourselves and pondering on is it efficient to educate all the nurses with some midwifery skills, or is it better to educate a few with comprehensive skills? And I would suggest that it's better to educate a few with comprehensive skills. So we were looking at whether increasing the confidence of the nurse midwives would help with their midwifery care. So we use lots of pedagogical approaches, structured learning experiences. We use clinical supervision and mentorship, which is a model adapted from UK practice. Findings from a study it concluded that the knowledge and skills of students may be enhanced using different classroom techniques. So other than traditional didactic lectures, our idea was to try and enhance the knowledge and skills using simulation workshops, small group seminars, role play, feedback, and in particular a skills and drills workshop with hands-on, real-time obstetric emergencies. So students can then make their mistakes in the safety of the skills laboratory and reflect on their learning in a more methodical way. We did the project. We did the gap analysis in September 2014. Then myself and a colleague did a 1-week mentorship workshop. And we were trying to train people to then train the clinicians in the clinical area. It was a multidisciplinary workshop, so we had obstetricians, gynecologists, we actually had dentists, pharmacists, nurses, and auxiliary nurse midwives from rural health centres. So we wanted the clinicians to be able to teach the students when the students were out in practice. We gave DVDs out, and we also directed all of the delegates to online packages that they could use after we'd gone home. And one of the lecturers in the UK, one of my colleagues, was in constant contact, weekly contact, with the lead for the project in order to evaluate what was going on and to answer any questions or queries, successes, and those things that might be challenges. So when we did the mentorship workshop, we also used a variation of different teaching and learning strategies. We did some lectures, but we did lots of small group work and feedback to the rest of the group. We did role plays where I was the student and Steve was the clinician. We then came back several months later to do a week-long obstetric emergency course. So we did a skills and drills workshop, which was basically very much part of our curriculum in the UK. It was multidisciplinary, which it is in the UK. It was set in real time with myself and a colleague, and the topics that we were concentrating on were fulminating, preeclampsia, eclampsia, undiagnosed twins, hemorrhage, vaginal breech delivery, shoulder dystocia, and sepsis. So we brought with us some equipment from the UK, and we used equipment here from India. We did the workshop in the skills lab at the Institute of Nursing Sciences. And we were, as part of the workshop, we asked the attendees to go to collect what they needed from the table as their sort of resource. My colleague was sometimes involved in the role play, so I think she's probably having a eclamptic fit there. And we also laminated and highlighted some things that we hadn't got. So magnesium sulfate intravenously. I wrote it on a piece of paper, laminated, and the students could take that from the table. This is just more simulation. Again, there were auxiliary nurse midwives from rural health centres, which was really, really pleasing for us attending. This is shoulder dystocia using the simulation techniques. So after we had demonstrated, then the students got involved and had hands-on practice with all of the emergencies. Another part of the curriculum that we wanted to enhance, and we still need to do further work on, I think, is normal birth. So we did a normal birth workshop for a day, where we talked to mainly the lecturers about UK normal birth practice. So we talked about water birth, which is quite unfamiliar in Indian practice. We talked about the use of aids to support women in labour, positions that women could adopt to aid birth, because mostly women in India seem to be lying flat on their backs and not able to sit up or move around, and that's partly because there isn't the space in the labour room to do that. We've talked a lot about the use of nitrous oxide and oxygen for pain relief, which you don't yet use in this part of India, but I believe they are beginning to use it in other parts. We talked about nutrition in labour, dignity, and empowering the women to make decisions about their own labour and who they may want to support them in labour, relative, friend. This is where we were showing a water birth on the computer to some of the delegates that were there. And we talked about, as I've said, we talked about the use of birthing balls, different positions, the use of using your birthing partner to support you in a more upright position to aid delivery. I've got some, they're not terribly graphic, but I've got some pictures of a woman in the water. So women in the UK can opt for water births at home or in midwifery-led birthing units or even on obstetric-led units they can opt to labour in the water, and a lot of women find that very relaxing, the warm water very relaxing, and not need to use any other sort of pain relief. The babies are born in the water, and sometimes the placenta is delivered as well in the water. And sometimes the dads get in as well in the UK. The National Childbirth Trust in the United Kingdom are particularly helpful with the promotion of normal birth, and they issue posters that we have in our delivery rooms that we showed the Indian students and lecturers about positions that women can adopt in labour to make your labour shorter and easier, hopefully. So keeping upright. We also talked to the students, myself and my colleagues, about their experiences. And we also have, last year, 5 of my students came on an elective, an observational placement, and worked in the main hospital facility on the labour ward, but they also went out to rural health centres to see what was going on there, and another 5 of my students are coming out this August. So we have developed this collaborative relationship, and some of Dr. Raddy's students are hopefully going to come out to the UK to observe our practices as well. So we held an international conference here in October last year and discussed our project findings and discussed the gap analysis that we did with the International Confederation of Midwives. And we hope that the work that we've done, even though it was small-scale work, that we hope that it's sustainable, because we were training people to train other people. We hope it's one of longevity, that we have a growing partnership, and I think we do, and we are hopefully going to be writing up the project to publish in joint research publications in journals. Thank you.